Starting just kind of talking about the different drugs. Acute pain is really kind of basic to treat from one aspect, but it also can be really complicated to treat, and it's going to depend patient to patient. It's going to depend on a lot of the situation you're in, whether you're post-operative or like in an urgent care, could vary drastically for what you're going to do. So I'm not really going to talk about acute pain from like an algorithm point of view, but I do want to talk about some of the scenarios we're going to use, and I'll have some practice questions and stuff. I think they're already on the RA lecture or the bone lecture. One of those two has some practice questions on it if you guys want to look ahead. But anyway, this is the way the WHO analgesic ladder was developed, and this has kind of been the standard for how we treat acute pain for a long time. And this is really the basic component of it. I'm going to talk about how some people are kind of messing with this a little bit and making it a little bit more complicated and probably a little bit more practical too at the same time. But basically you start with non-opioids, so you use drugs like NSAIDs and acetaminophen or Tylenol and Advil, those types of things, and then you work your way up to like a medium opioid, which would be like tramadol or codeine, and we'll talk about those, and then you work your way up to the full opioid. The point is that full opioids should be kind of reserved for the more severe pain. Now, sometimes you might want to go directly to a full opioid, though. So if you have a surgery and I don't know a lot about surgery, but let's just say some spine surgeries are very high pain in the post-op period. So those patients might go straight to an IV opioid for their pain management. And that's really common. So don't feel like you can't go directly up to the top of the ladder. It's more or less a guideline for how you should think about pain. And you can always combine things too, which we'll talk about adjuvants and things like that. Essentially, this is kind of the way to think about pain is like, okay, so if I want pain options, I'm going to start at the bottom of the ladder and think about how I need to add or when to add, or do I switch, or do I go straight to the top of the ladder? Do I add something from the bottom of the ladder too? Usually the answer is always yes. You're almost always going to combine non-opioids with opioids, and hopefully you get some synergistic effects, but it depends on the patient and the scenario as well. Somebody decided to take this ladder and make it a little bit different. So they took the WHO ladder and added a couple different things to it. So you can see the difference. So steps 1, 2, and 3 are basically the same thing. Step 4 adds a bunch of other stuff. So stuff that the WHO ladder doesn't even talk about, like nerve blocks. You guys talked about like ropivacaine, bupivacaine, those types of drugs yet? Yeah, I'm not really going to talk about them a whole lot, but it's very procedural related. I'll mention them very briefly, kind of when we talk about neuropathic pain. But anyway, you can block the nerve impulses using local blocks. That's how they do, especially orthopedic surgery. They do that a lot. They give these drugs called either ropivacaine is pretty common, or bupivacaine. But all drugs that end in cane basically block nerve impulses. That's what they do. So that's what a nerve block is. So think about it like an epidural. Who's here has had a child or knows somebody who has had a child? So if you get an epidural, that's what they're doing, is they're putting bupivacaine or ropivacaine, either one, depending on what institution you go to, into the epidural space, and that's preventing nerve impulses. Now, it sinks down far enough in the epidural space so it doesn't really block nerve impulses. Usually, it's kind of like below the diaphragm is where you want it. Once, I don't know, anesthesiologists are funny. I had one calling me frantically saying, I'm getting numbingness above the nipple line. What should I do about that? I'm like, what am I supposed to say to that? I don't know. It's like, what's wrong with your product? It's like, yeah, because I make the product. Thanks. So anyway, nerve blocks can be used situationally depending on where you want to put them and how you use them. They're very situationally functional and have some really good utility. And if you can get a nerve block in, you can kind of avoid the whole need for opioids and stuff like that. Yeah. So we talked about epidurals, which are kind of like a nerve block too. I'm going to talk about PCAs, which are patient-controlled analgesic options, which is kind of like, usually those are opioids. You're just giving them as an infusion and with a bolusing strategy. And again, I've got an example of that coming up. Neurolytic block therapy and spinal stimulators, I know nothing about. I'm not even going to pretend to talk about them, so you can look those up on your own if you want. But the point here is that they're kind of looking at this ladder and expanding on it a little bit to say there are other options beyond opioids to consider for your patients, and to think about also including the adjuvants as you increase in your steps as well. So there's some changes there, but overall it's pretty much the same concept, and nothing has really changed with the way the WHO approaches pain to the way we normally approach pain in most situations. Okay, so let's talk about NSAIDs and work our way up to opioids. So NSAIDs are non-steroidal anti-inflammatory drugs. estimated that about 17 million Americans use an NSAID on a daily basis. It's probably higher than that, I would imagine, actually. Really common drugs used worldwide. In fact, USA gets kind of a bad reputation for using opioids and kind of jumping straight into opioids, especially for like post-operative pain, whereas in Europe they actually use a lot more NSAID therapy. There's debates on whether that's smart or not, because in the doses they use sometimes the side effect profiles can shift to have higher incidences of GI bleeds and stuff like that, but then they'll argue, well, all your people are addicted to opioids. It's like, well, not all of them, but yeah, you kind of get your point there. So anyway, use will increase as population shifts. Like baby boomers are kind of shifting into that phase of being elderly as we speak. So that's going to be something that, just as the body ages, joint degeneration and osteoarthritis kicks in. And so we're going to see a lot more NSAID use. So NSAIDs aren't going to go away anytime soon, and people are going to continue to use them probably for quite a long time. Historically, they were one of the first pain medications used. Salicylates were used exclusively until 1950, and non-salicylate attempts were toxic. So the first attempts at like a true NSAID, like an ibuprofen type analog, were toxic at first. However, eventually somebody developed a drug called indomethacin in the late 50s that was proven to be safe. So NSAIDs have been around a while, both in their like aspirin, salicylate type forms and in their newer forms as well. So we have a lot of experience using them. Modern day, we have about 20 different NSAIDs on the market. There's 6 different pharmacologic categories, which doesn't mean anything to us because they all do the same thing. So when I break them down into different categories, I kind of do that, but I kind of got rid of some of that too. Don't worry about it. They're all basically the same with the exception of one NSAID and a couple little caveats I'll give you here and there. The big differences between them is how long they last, and also it can be how potent they are. Some people might just experience more potent effects from certain ones than others. Some are over the counter, like ibuprofen and naproxen are over the counter. The rest of these are all prescription only, so sometimes that depends on what you might prescribe as well. Again, short-acting versus long-acting NSAIDs are an option. So somebody who's taking it for osteoarthritis, instead of taking, like the commercials say, right, oh, I have to take Aleve, you can take twice a day as opposed to Advil. How many times a day do you have to take that? It's kind of true, but at the same time, somebody might say, well, Aleve doesn't really relieve my pain, and I find I get a lot more effect from ibuprofen. So there's that patient variability too. Toxicity is variable, and I already said patient response is variable. So anyway, let's get into more of this detail. Just to review our mechanism of action, we talked about this last fall, but just quickly again, arachidonic acid is the major kind of upstream transmitter here that is an eicosanoid precursor. So once there's some sort of a tissue damage or inflammation, or that's going to lead to inflammation eventually, you end up releasing arachidonic acid, which causes eicosanoids to be upregulated and produced, which causes an inflammatory and immune response. Arachidonic acid gets converted to a number of different things called prostaglandins, prostacyclins, thromboxanes, and leukotrienes, some of which have to do with pain and some of which, as we already know, do not. And just to review the slide that shows it nice and neatly, your arachidonic acid pathway with the cyclooxygenase enzymes will make these things eventually. And so if you break that pathway from happening by blocking the enzyme, you ultimately reduce production of those products. Okay, so what about COX-1 versus COX-2? COX-1 is our constantly active cyclooxygenase enzyme. It's responsible for generating housekeeping prostaglandins and has gastric epithelial cytoprotection. So it's a good one. We don't really want to inhibit COX-1. It doesn't really do us a whole lot of good to stop it, but most of our drugs do that because they aren't selective for one or the other. Or at least they're somewhat selective, meaning they might do a little bit more COX-2 than one, but they're all going to hit COX-1 a little bit with the exception of one drug. COX-2 is our inducible one. It's upregulated depending on stimulus, and it's our major source of inflammation and also some cancer-related prostaglandins. It's a pretty oversimplified way to look at it, but general concept behind the pharmacology of NSAIDs. The whole inflammatory process, as I dipped into a little bit last fall, is complicated, but I think that's pretty much, from my perspective, all I need you to know for this. Okay, so this chart is sort of correct. I think it does give you a little bit of a kind of shades of gray within NSAIDs. Let's go to the bottom at first. COX-2 selective. It looks like there's a lot of drugs here. The only one I care you know is celecoxib. Meloxicam and etodolac technically aren't COX-2 selective. They're very heavily COX-2 oriented, but they do have COX-1 activity. Celecoxib is the only drug on the U.S. market that is COX-2 selective. There aren't any others. There have been some other ones. These ones are, again, say no longer available or investigational. There was a drug called Vioxx that was out a while ago that had some issues with it that we'll talk about in a moment here. Non-COX-2 selective NSAID just means that it pretty much inhibits COX-1 and COX-2 with equal affinity. So you have ibuprofen, naproxen, so it's like Advil, Aleve, your common ones, ketorolac, which is another super common NSAID. And then when they say with some COX-2 activity, that's a little, I should just make my own table, right? This is silly. I don't know why I haven't done that. Some COX-2 selective activity means that it's a little bit heavier for COX-2 versus COX-1. So maybe think about it like 75% COX-2, 25% COX-1. But again, the major message here is that if you really want COX-2 selective, you have to go with celecoxib. There's no other drug on the market that's purely COX-2 selective. And that's the take-home message. But if you want to get more into the weeds, this slide's for you. All right, safety concerns with NSAIDs. NSAIDs we talked about being renally toxic. We already covered that pretty heavily last fall. Pregnancy concerns. Pregnancy concerns is a little bit debatable on when you can take NSAIDs. It seems pretty clear that there are some risks with pregnancy, and generally speaking, pregnant patients will be told not to take NSAIDs, and that's probably a good rule of thumb overall. If you can get by without them, go for it. Some people might need them for various pain disorders, so at a minimum, if a pregnant patient is going to take them, avoid it during early or late pregnancy. Late pregnancy is more associated with bleeding risk related to the delivery phase. And early pregnancy, there is some evidence of birth defects with some early use. And also, we'll talk about patent ductus arteriosus, which is a complication that can happen to children who are preterm during the pediatric lecture, but that has to do with NSAID-related use late in pregnancy as well. It's easily fixable, but it is something that happens occasionally. GI bleeding, so that's the other big one, probably the most common one to remember when it comes to NSAIDs. I always think renally toxic, GI bleeding, and then again, kind of watch your pregnancy status on your patients. This is some studies that show you about how the relative risk on different NSAIDs and their GI bleeding risk. So some of these drugs don't matter because they're either like European ones or we don't have them on the market anymore. But you can see ibuprofen, for example, is actually one of the lower risk out there for GI bleeding. It's the most common NSAID people take, and it's probably actually one of the safest. It's a relatively potent one too. I'll talk about this in a minute, but there really isn't one NSAID that we know for sure is way more potent than another. There's actually a lot of studies that prove they're pretty much all on equal footing, which is a little bit controversial, but I'll get into that more in a second. Also here you can see this is also GI bleeding risk as well with just some different NSAIDs here. And you can see this one I put in here because it has ketorolac on it. And ketorolac is consistently rated to be one of the highest risk for GI bleeds. In fact, you don't usually use ketorolac more than 5 days because of that risk. And we'll talk about ketorolac a lot more on a different slide here. All right, this really cool drawing with the lightning bolt hydrogen ion here destroying the epithelial layer of the GI tract. So NSAIDs disrupt the mucosal gel layer of the GI tract, which is where those good housekeeping prostaglandins take care of that. And if you don't have that, well, you could possibly get an issue. And then ultimately, acid gets onto the cells, causes cell death and damage, and then you get a GI bleed. Of course, that's not going to happen to everyone. It's not going to happen to a lot of people, most people that take NSAIDs. But if it does happen, people who are at higher risk would be people who are older, so age 65 or up. Creatinine clearance less than 40, so people who aren't clearing it renally as much. Of course, histories of ulcer or GI bleed. Drugs that would cause you to bleed in the first place, right? So anticoagulants, antiplatelets, glucocorticoids, SSRIs. Maybe SSRIs are antidepressants. We haven't talked about those. That's kind of a weak correlation, but it's there still. The big ones are obviously the antiplatelets and anticoagulants. Those are the ones to be concerned about. Consider chronic versus PRN usage. So somebody who takes ibuprofen once a month for a headache has virtually no risk of a GI bleed. Somebody who takes it 3-4 times a day for osteoarthritis, much higher risk. So think about how often you're using it. And also the dose, which I'll talk about in a second here too. There's some interesting literature out there on dosage and where to stop and how high you go with these drugs. Prevention. Limit use overall. That's the first step. If you can't do that, the COX-2 selective one, which would be celecoxib, would be your preferred agent. It doesn't have the COX-1 inhibition, so therefore you get less GI risk with it. Or you give it with a proton pump inhibitor. Usually if somebody's on chronic NSAID therapy, they should probably be on a PPI as well. We'll talk about that during GI in the next module, but those are like our Prilosec, Nexium drugs. The common heartburn medications you can get over the counter, you're going to want to be on that regularly during this, just because there's really good evidence that says it does prevent GI bleeding and decreases your risk. If you can decrease acidity, you can decrease the ability of hydrogen ion to attack a possibly exposed epithelial layer. And then again, the COX-2 selective one would be an option. So why isn't everyone on COX-2 selectives? Well, there's a lot of risks with that, and I'm going to talk about those separately here in a second. Other drug interactions to consider. There's a couple different things on here to think about when it comes to NSAID therapy. Lithium, don't really worry about this too much here. Lithium's a common med for bipolar disorder, but that's it. If you don't see patients in psych, you probably aren't going to see it a lot. But if you do see somebody on lithium, it's probably just best not to use NSAIDs. The problem is lithium has a really narrow therapeutic window, and NSAIDs interfere with its ability to be cleared correctly. So if you're taking them in conjunction with lithium, you can end up getting lithium toxic, and it gets toxic pretty quick. So that's just a no-no overall. We try to avoid that one. Antihypertensives. So NSAIDs work against the body's ability to naturally vasodilate. So if somebody has borderline hypertension or hypertension and it's undiagnosed or whatever, and they're taking NSAIDs regularly, that's actually going to contribute to increasing their blood pressure. So people with uncontrolled hypertension, we usually try not to use it with. People with hypertension in general, not a great idea. But again, you run into these questions where you're like, well, I've got this person who's well managed on their lisinopril. Can I use an NSAID? And the question I'd bring it back to is, what's your dose? How often are you using it? Is it a regular thing? Have they tried other options like Tylenol? That's where I'd go with that. And ultimately, yeah, you can combine them if you want to. I'm a big proponent that we should try and get our patients pain-free if we can, and not be like, oh, sorry, take losartan, can't prescribe that ibuprofen for you. Let's try and work with the person and monitor them, maybe see if they can do some home blood pressure monitoring and make sure it doesn't go that high. I don't think it's going to like skyrocket the blood pressure, but it is a contributing factor. And again, especially if that person has uncontrolled or difficult to control blood pressure, that would be where I'd get a little concerned. Doubling up on NSAIDs, don't do it generally. It's common sense for us, but not necessarily to somebody who doesn't have a medical background. So naproxen and ibuprofen are both over the counter. They're in a lot of stuff as combination therapies. They're in a lot of different brand names. So you might not necessarily know you're taking the same ingredient and you're accidentally doubling up on your NSAID. It's definitely not recommended. It doesn't do any good to combine them. You don't get any added analgesic relief. You're only going to increase your risk for a GI bleed if you do that. Okay, so I mentioned COX-2 selective drugs are good if you want to avoid a GI bleed. However, I also mentioned that Vioxx was a drug that was taken off the market for some reasons. And the reason is because there's a thought that COX-2 selective NSAIDs increase cardiovascular risk. So thought to increase thromboembolic related complications due to decreased prostacyclin production, which can predispose you to vascular endothelial injury and some other things. Vioxx was on the market at the same time as Celebrex was, and it was shown to have a twofold increased risk of CV events compared to placebo. They pulled it from the market. Celebrex was able to kind of slide by the skin of its teeth and stay on the market. It didn't show actually a significantly increased risk at lower dosing, so they actually kind of adjusted some of the dosing recommendations on Celebrex. They found they still got decent and good actually analgesic response with the NSAID without having to go to a higher dose. Basically, if you have somebody at high risk for a thromboembolic event, or they've had like a previous MI or something like that, or they have heart failure, probably wouldn't use celecoxib at all. Just keep that one off the risk. If there's high CV risk, if they have family history or something like that, that's kind of a debate you could have with the patient, or a discussion you could have with the patient, but I would probably recommend erring on the side of not using them in patients who have high CV risk. All right, so the COX-2 selective or COX-2 heavy ones carry the highest risk. However, we talked about all NSAIDs inhibit some form of COX-2, right? That's how they give their analgesic response. So every NSAID technically has a risk. So you might read articles from time to time say, oh, everyone who takes ibuprofen is at risk of a heart attack. It's really not true at all. In fact, a lot of them have quite low risk when looking at the evidence we have available to us. And again, millions of people take these, so we have pretty decent pools of evidence to pull from. Naproxen is thought to have the lowest risk, and actually at higher doses it can have a sustained antiplatelet effect. So whatever effects the COX-2 is causing to increase thromboembolic complications, the antiplatelet effect might counteract that to a certain degree. However, they all technically carry that risk. So what is the actual risk? Stroke, MI, heart failure, AFib, CV death, and the risk is really small. It's like 1 to 2 per 1,000 person years. And especially if a patient has low CV risk and they're taking it for short-term or PRN therapy, the risk is essentially 0. So don't let this scare you from prescribing them. Just know that for people with high risk cardiovascular or neurovascular, like stroke, be the other thing to throw in there too, those would be people to maybe not use NSAIDs in regularly. All right. Aspirin interference. So NSAIDs kind of mess with the arachidonic acid pathway, and if you are a studious person or just maybe an observant person, you might have said, well, what about the thromboxane component there? And don't these kind of do the same thing as aspirin ultimately? And yes and no. So NSAIDs actually interfere a little bit with antiplatelet activity with aspirin because they compete for binding of aspirin on the COX-1 site. So aspirin actually inhibits arachidonic acid. It also binds to COX-1 directly. It prevents an irreversible reaction for the life of the platelet, and the pharmacodynamic interaction is not really seen with two NSAIDs, so celecoxib, which is our COX-2 selective, and another drug called diclofenac. Ibuprofen and naproxen have both been shown to interfere. However, there's a nice get around for this. Just space the drugs about 2 hours apart. The idea is once the drugs are fully absorbed and metabolized into other forms or do their thing, so like aspirin, once it's absorbed and in the bloodstream, should bind to platelets and do its aggregation inhibition thing without having to get interference from the NSAID. And then once you get the NSAID, you shouldn't really have an issue with that. So you can space them 2 hours apart. Naproxen is probably the lower risk one if you're looking at one or the two, but it does have a longer half-life, so the spacing gets a little trickier with that. Anyway, don't worry about this too much. So it's just something that's out there and you might read about it. It's a pretty well documented interaction, but clinically speaking, we don't really know the implications of it. And that's one of those things where pharmacologically and pharmacodynamically we see an interaction here, but clinically we don't know if this is really that relevant. So it's again something you might have to just kind of decide patient to patient and think about it from the standpoint of what's this patient's risk? Have they had previous events in the past? Is it worth it to give them the NSAID? Why are we giving the NSAID? And think about it that way. NSAIDs are of all kinds, COX-2 selective or not, are contraindicated for perioperative pain in CABG surgery. So post-bypass surgery, they don't give NSAIDs for this very reason. And that's really the only time where this is actually contraindication based on this interaction. Otherwise, it's not a contraindication, it's just sort of a precaution type thing. All right, let's talk about some more interesting things that gets kind of technical and in the weeds. So ceiling effect, I like this one because it's sort of turns medicine on its head and kind of what everyone was taught and what are we using these drugs for actually. So there's a theory out there that says you can only get so much analgesic response out of an NSAID. If you push the dose higher, you're going to get more side effects, but you aren't actually going to help with pain at all. And there's two ceilings potentially too. This is the other part of it. There's an analgesic ceiling. So if somebody needs to take it for a headache that they get once a month, that works for that. But if you're actually trying to suppress inflammation, like maybe for a rheumatoid arthritis patient, you actually need a higher dose to get to that point. So for example, ibuprofen, the ceiling for pain would be 400 milligrams, which is 2 over-the-counter tablets, and 800 milligrams for inflammation. Now, could you take 800 for pain? Sure. Is it recommended? I don't know. This is where the evidence will tell you basically that no, it's not. But the studies are quite small. So a lot of the goals in literature are designed for rheumatic conditions, which are going to have that higher anti-inflammatory related ceiling that they're targeting. But like some of the studies out of smaller studies, anyway, a couple hundred patients out of the ER will show you that there's no real advantage to using a higher dose of ibuprofen. You get the same effect with both. So there's a lot of interesting evidence out there. I'm going to talk about ketorolac and why that's controversial too, because that's considered the most potent NSAID, and there's some interesting studies with that one too. So we'll come back to that here in a second. But just know that a higher dose with like an ibuprofen or an naproxen just for pain control, for acute pain, isn't necessarily going to give you that analgesic response you're looking for. Okay, aspirin. We talked about aspirin with respect to antiplatelets quite a bit. analgesic use, it's minimal. You can take a lot of aspirin for analgesic use, but it causes poor GI-related side effects. So to get the doses you're going to need to actually have an effect, people aren't really going to tolerate it. So we can pretty much write that off for pain. Every once in a while, I talk to somebody coming into the hospital who takes like a 325 milligram aspirin every once in a while, and they say it works for pain. I don't really believe them. It's probably placebo. But it's, if they're doing it and they're taking it regularly and like causing a bleeding risk or anything like that, then I guess it's okay. Salsalate is a really weird drug that no one uses all that much. However, it's kind of an interesting option. It's not really a full NSAID. It's not really aspirin either. It's kind of like rides the line in between. It's not as risky. You don't have those GI-related bleeding effects as high with NSAIDs. So if you had somebody who you wanted something that wasn't an opioid and wasn't an NSAID and wasn't Tylenol, that's pretty much the only drug you could try. So sometimes it's used, but it's, again, not super effective based on evidence. Not as effective as like an ibuprofen or an naproxen. All right, Tylenol. Tylenol is not really an NSAID, but it doesn't fit into a category. Tylenol, actually, no one really knows how it works, which is kind of funny because it's probably the most common drug taken in the world. It probably inhibits some form of COX pathway, but we aren't really sure. There's a theory that it might be like a COX-3 enzyme that works in the central nervous system that it inhibits, but no one knows exactly how Tylenol works. Tylenol in the UK and Europe is called paracetamol. So if you ever hear that term used or read that, that's what they're referring to as acetaminophen. And APAP is a really commonly used abbreviation for Tylenol. It stands for N-acetyl P-aminophenol, which is the chemical compound. So if you want to impress friends and they're like, why does this drug say APAP on it? Well, now you know. Tylenol has some very specific dosing parameters with it. It's really generally quite safe. However, if you take too much of it, you can get hepatotoxic with it. So I want to make sure you keep within your guidelines. But also, I'm a big proponent of, if you're going to take Tylenol, take a whopper dose of it. Don't take like a mini dose, because you're probably not going to get an effect with it. I'm not saying to overdose yourself, but take like the full dose for an adult patient, especially if you're trying to target pain. Okay, so 325 to 1,000 milligrams, Q4 to 6 hours as needed. You don't exceed 4 grams per day. So I tell you when I want you to know doses. I want you all to know the max daily recommended dose of Tylenol for the exam. I will have a question on there. It's very straightforward, and if you don't know it, you'll get it wrong. So here it is. 4 grams a day is the max daily dose for adults. For kids, it's a little different. It's 10 to 15 mg per kg. And you give 5 doses total per day. So whatever that total ends up being would be your total daily dose for kids. Or if they're a heavy kid, like, sometimes you get low teenagers who are more adult weight or heavier, and it's above 4 grams, I wouldn't ever give above 4 grams. So use some common logic there, but generally speaking, that's how you do it. Semi-effective pain reliever, I say that kind of with some hesitation because most studies say it's not really all that effective pain reliever. It's basically a slight step above placebo, and a lot of studies will say it's statistically similar to placebo. It doesn't really have much of a pain effect at all. Some people think it works great, and I'm a big proponent that if that works, it's a relatively safe med, go for it. I think it's usually worth a shot, and there's some interesting evidence with Tylenol that it does work synergistically with other drugs. So by itself, it might not be that great, but in combination with opioids and postoperative pain, you might be able to get away with lower amounts of opioids than you would if you just gave that without the Tylenol. So don't dismiss Tylenol because it's not effective, because it probably isn't by itself, but it's worth a shot. And the nice thing about treating pain, it's not like treating blood pressure where you have to wait a couple weeks to see your full effects of your drug. You should see the pain relief fairly quickly. So you take Tylenol, it absorbs into the body. Let's maybe give it an hour at most, and if you don't get pain, let's move on and try something else. It's a good antipyretic, so especially for kids or adults with fever, it works pretty well to bring fever down. And you can use it in conjunction with any other pain medication. That includes NSAIDs. Safe in pregnancy. There's some debate on this always. People are trying to rag on Tylenol's safety in pregnancy, but I haven't seen anything convincing that would tell me not to take it. So, Tylenol comes as an IV product. It's called Ofirmev, and it's kind of expensive. So a tablet of Tylenol probably costs 2 cents, and a bottle of IV Tylenol is like $125. So we get people who really like this, and there's some studies from the company that made this that say that if you give IV Tylenol in postoperative conditions, you drastically reduce opioid use. Now, the problem is they didn't compare that to using oral Tylenol and opioids. They just compared it to just not using Tylenol at all. And it's like, well, hello, you guys trying to sneak a fast one by us? So sometimes you just really got to read between the lines on some of those studies, because it sounds really good at first, but at the end of the day, like, you got to think critically about some of this stuff. And ultimately, this drug, I don't think shows all that much promise, but we do use it. It does have a great role for people who are NPO. They can't take anything orally, and you don't have another option. It's good for that, but otherwise, it's something that we try not to use if we can avoid it. Tylenol is combined in virtually everything you see in the over-the-counter cough and cold aisle, which makes it extremely dangerous. So if you're taking Tylenol already for pain by itself and you get a cold and you start to take more Tylenol because you didn't realize Dayquil has Tylenol, essentially everything has Tylenol in it. So always check any combination product and make sure you aren't doubling up on it. It's a good message for your patients. There are some opioid painkillers out there too that are controlled substances that combine Tylenol with the opioid narcotic. Just make sure that the patient isn't taking more Tylenol on top of that. It does not really have any drug interactions except when you take a bunch of it and it causes hepatotoxicity, then it'll affect the way the liver processes drugs, but that's way down the road. By itself, you don't really have any issues. I work with some pharmacists that claim it interacts with warfarin, but I don't really believe them. I think they're just making that up. Hepatotoxicity. So that's probably the biggest thing to remember about Tylenol related from a safety profile is the hepatotoxicity, and remember that max dose of 4 grams per day. If you exceed that by a little bit, probably not a big deal. Usually for an adult, the toxic dose is around 7 to 10 grams, somewhere in there. In one 24-hour period. So sometimes people might accumulate enough throughout the day if they're chronically taking, let's say they chronically take 5 or 6 grams a day because they don't really know any better. No one told them not to. We'll give them the benefit of the doubt, right? Maybe they're taking it 1,000 milligrams every 4 hours because that's what it said on the bottle and they didn't read the max or something like that. Who knows? So anyway, they ended up overdosing themselves slowly. That can build up over time. But in an acute ingestion, you're looking at like 7 grams, and if that's kind of probably be okay in most patients. There's a lot of deaths annually due to accidental and intentional acetaminophen overdoses, so it gets kind of a bad rap as being a highly dangerous medication, but it's just because it's so easily accessible. Everyone's got Tylenol, and it's one of the first things people might have access to or think about if they're trying to intentionally overdose. Yeah.
Does alcohol intake increase the toxicity?
That's a good question. Directly, no. Indirectly, excessive alcohol take might kind of shock the liver into a state of not being able to metabolize much at all. And so you could end up with accumulation. But the problem with Tylenol, and we'll talk about this during talks, is a toxic intermediate. So it actually has to do with how the liver processes it. When it metabolizes it, it converts it into something that normally just gets shot out of your system just fine. But if it runs out of the enzyme that can process that, it converts it into a toxic intermediate, and eventually that'll cause hepatocellular death. So I think the combination of the two, I'd be more worried with like a chronic alcoholic who's already got some liver damage on board than like somebody who did an acute alcohol ingestion with Tylenol. You'd see different effects, but I don't know if you'd really see compounded hepatotoxicity with that. Possible, but it's hard to say. Anyway, we'll come back to Tylenol overdoses in detail during talks this summer. So hold your horses on that. Just remember hepatotoxic and remember the max dose. Ibuprofen, so Advil or Motrin, common brand names here. It's the most commonly used NSAID. All of us in here have probably taken it at some point in our life, just like Tylenol. Very similar to acetaminophen when it comes to OTC use, prevalence, combination products. Dosed 200 to 800 milligrams Q8 hours. Max is 3.2 grams a day, which kind of gets people scared. They're like, oh, I didn't know I could take that much ibuprofen. Well, if you look at some of the indications like RA for people who take it during a flare or something, yeah, it's pretty high. But for most people, they're probably going to take like 400 to 600 is probably where I would recommend people take. I don't think you, again, based on the studies, I don't think you really get much analgesic relief much higher than that. OTC tablets are 200 milligrams, so if you do want to direct somebody to take more, it's okay to do that. So like, let's say you wanted the anti-inflammatory benefits, certainly no problem with somebody going to and buying it over the counter and taking 4 of them at a time to get that 800 dose. However, you can prescribe it in RX strength, which would be 400, 600, 800s. It comes in all those different formulations. You ever seen the 800s? They're a big whopper of a pill. So it might be better for somebody to take 4 of the little 200s than a big 800, depending on how well they can swallow a large tablet. All right, lowest GI bleeding risk on non-selective agents. but it does have high risk because people take it chronically and at high doses really commonly, and sometimes without discussing with a provider about safe strategies for doing so. So that's why it's a bit riskier, at least if we look at the grand scheme of things and everything else. But really, if you look at its relative incidence compared to how many people take it, it's lower compared to other ones. Minimal other side effects. There's really not a lot of side effects with NSAIDs other than that GI bleeding, which is why a lot of people take them. And better pain control with acetaminophen. Virtually any study that looks at Tylenol versus an NSAID, NSAIDs always win. They don't lose to Tylenol. So Tylenol is pretty much proven to be inferior to NSAIDs when it comes to analgesic relief. It also is a really good antipyretic, so you can use it in kids too. So if you want to get better pain control and fever reduction in a child, the NSAID's probably the safer way, the better way to go for efficacy. Again, you have a few more issues with the GI bleeding risk, but overall, it's relatively safe. Naproxen. Naproxen is a long-acting over-the-counter medication, and I put the slide on this one and ibuprofen just because they're by far the two most commonly used ones. It's a twice daily. It's got about a 12-hour half-life. Dosage range. The over-the-counter product is 220 milligrams, and you can get it up to, I think the prescription version comes as 500, and you can do 1,000 milligrams for a dose. It's rare to see it that much. Usually I see it cap out around 500, but again, if you want those really strong anti-inflammatory effects, you might want the higher dosing with it. Yeah, that's all I really want to say.
Does that make any difference, like what kind of pain patient has?
Yeah. I'm going to talk briefly about neuropathic pain, but that would be the big difference. So if you're talking about somatic pain, it's kind of all the same. More or less, it's worth trying any of these. If you're talking about neuropathic pain, that's where you'd start down a different pathway. Ketorolac, considered by some, I should say, to be the higher potency NSAID or the highest potency NSAID. However, there's actually a lot of controversy over how true that is. The reason why people think Ketorolac or Toradol is the brand name of this. I don't have that on there. But Toradol, which you'll hear people use that brand name all the time, people give this out like water, especially if you work in the urgent care or ER. You'll see this used all the time. And we had this really young, why am I saying young? I like to think of him as young because he's a newer pharmacist. And sometimes when people come into our department, when I used to be in the ER, it's like, oh, they're bright-eyed and bushy-tailed and they want to make change. Good for you. I'm not willing to do that sometimes. But so he had read a couple of studies that said that the doses that people were using of Ketorolac were way off base for analgesic response. The reason why people really like Ketorolac is because it comes IM or IV. So the idea there is it gets right into your bloodstream and maybe be more effective than a PO version. However, that's not actually proven. And he pulled out a bunch of literature that said things like, if you compare an injection of Ketorolac to an oral dose of Tylenol, you don't actually get, or Tylenol, sorry, an oral dose of ibuprofen, you actually get the same response. And the way some of these studies were set up is they would inject people with saline and give them a cup with the tablet in it, and then they'd placebo reverse it for the other control group. So they'd actually be getting the Ketorolac and then a placebo pill, and the people with the tablet versus the actual shot didn't have any difference in their pain control. In fact, they're both equally controlled well. So the interesting thing was, are you getting some kind of a placebo from getting an injection specifically? And so a lot of times I think that's why they do it, is you want something a little stronger as a provider. You don't want to give them an opioid. So, hey, I'll give you an injection, a shot of IM Ketorolac, and you can kind of explain it. It's like ibuprofen, but it's a little stronger. They might say, oh, that might buy you some time to let that sink in and hopefully avoid prescribing an opioid to somebody if you don't have to. So it definitely has some use there, and I'm not arguing against it by any means. I think it's got a really great role in therapy, and it's great for people who are nauseous or whatever, and you want to get some NSAID on board. It's the only NSAID we have that comes this way, so it's only one you can give IV or IM. So again, it's a great drug from that perspective. But there is a lot of, again, smaller studies that are kind of pushing this trend, saying that this isn't any more effective than ibuprofen. And for years and years and years, we've always thought, yes, this is a significant step above oral ibuprofen. And what we're seeing now is it actually probably isn't. Now, the dosing is a little different. So it comes as a 15, a 30, and a 60. So this pharmacist who started in our department, everybody was getting either like 30 IV or 60 IM, and those are kind of the max doses. He pushed it all down to, so we don't give any higher than 15, because again, most of the literature says that 15 milligrams, if you give any higher than that, you don't get any more analgesic control, especially in the acute setting, and you don't get any, all you get is more side effects, right? Ketorolac has the highest GI bleeding risk out of any NSAID, so that's why we want to be really careful with using it. And so in this case, he actually did a really nice job working his way through our different committees and getting this approved, and actually did some work on the system level. So I'll give Zach kudos to saving our patients' GI tracts and still treating their pain adequately. All right, shows you what I know, right? Any questions on NSAIDs so far? I'm kind of moving through them. I've got a couple more to cover, and then maybe we'll take a quick break. Diclofenac is an NSAID just like any other. The only reason I put a special slide on it is because it comes as a topical option, and it's the only NSAID that you have that with. It comes as a patch called Flector and a gel called Voltaren. They're both generic now, and so they're, especially the gel, actually the Flector patches might be brand name still. Anyway, the Voltaren gel is the more commonly used one that I see, and it's generic now. It used to be kind of expensive, so now it's a little bit more affordable. But anyway, the nice thing about this is you can put this locally on a joint or someplace where you're having pain. People use it on their lower back, wherever it might be. And you get local NSAID anti-inflammatory effects and ultimately pain relief. However, you get minimal systemic absorption. So if you compare this with if somebody took an oral dose of diclofenac, they're saying it gets 100% bioavailable, which sure, okay, probably not. But let's just say, for argument's purposes, that's what happens. If you give somebody topical, you get 5 to 20% depending on the different doses you're giving somebody. So the nice thing is you can avoid major systemic exposure to the GI tract and to the kidneys specifically for patients who you don't want that. So for local pain that's really specialized or focused on a small area of the body, I think this is a really great option. I think people forget about it, so I really want to make sure I say something because I even forget about it too. I'm like, oh yeah, diclofenac, are they having knee pain? Let's try that. And it might not work, but it's worth a shot. And again, pain medications should work pretty quickly. Even topical ones, you should see some relief within a couple of hours if it's going to work. And it's a really popular drug. A lot of people seem to be getting use out of it. And if we're preventing the NSAID from getting to the kidneys and keeping people's kidney function preserved longer, that's definitely a win. So anyway, this has some good functionality if you're looking for a non-oral route. Other non-selectives. I don't have a lot to say about these. We're going to talk about indomethacin, and with respect to OB, it's used actually to stop preterm labor through a different mechanism that we'll talk about. Meloxicam, I'll point out, is being a mostly COX-2 agent with its once daily dosing. So that's a nice agent for people taking NSAIDs for osteoarthritis. If they respond well to it, it's a once daily drug. So you can't really beat that for pain control. Piroxicam, don't worry about it. Nabumetone, don't worry about that, and don't worry about the other two. So yeah, that's all I really want you to know. These ones are just, you see them used occasionally, but they're quite rare compared to the rest of them. All right, and then I've talked about celecoxib a bunch of times. So this is, again, the only viable pure COX-2 selective agent on the market right now. GI risk is minimal. However, even with chronic use, people will still recommend using a proton pump inhibitor. You might tell me that doesn't make sense, and I kind of agree with you. But at the end of the day, it's better safe than sorry. And some people think PPIs are harmless. I kind of disagree, and I'll talk about that later. But the point is it's lower risk to do that than to give somebody a GI bleed. So at the end of the day, it's probably the safer way to do it. Dose twice daily, no effect on platelet function. Doses over 200 milligrams a day are associated with increased cardiovascular risk, so we keep it under 200 a day. Best to avoid, again, if there's high-risk complications with celecoxib. So very popular medication. A lot of people end up taking this just because of the lower GI bleeding risk. So don't let that make your decision up for you. It is a generic option. It is relatively inexpensive, so there is that too. But don't feel like you have to prescribe this because it's lower GI. Just kind of think about your patient's risk, and if they stratify into some of those risk factors we talked about, this might be the way to go. Otherwise, the other ones are probably just fine, especially if you combine them with a PPI. We'll talk a lot more about, well, not a lot more, but I'll give you some more context for NSAIDs and acetaminophen use and those types of things during our osteoarthritis lecture, so we'll come back to that in 2 weeks from now. Let's do muscle relaxants quick and then take a break. I don't have a lot to say on these because they're not that they're not common, but they're very odd drugs that have nebulous mechanisms of action. And when you look at the WHO ladder, there's not really a good place where these fit in. I think I would kind of put them in the middle. They aren't an opioid, but they're not non-habit forming. Some of them actually do have controlled statuses associated with them. So anyway, they're centrally acting muscle relaxants, so they work on some sort of different combination of receptors in the central nervous system in the brain that cause a downstream effect that relaxes muscles. So for muscle spasms, short-term relief, acute relief, I think about people like post-spine surgery who are going to be on these. People who have some kind of a neuro-related injury where they fall and they have some sort of a neuropathic-related thing that's causing either neuropathic pain or it's causing some sort of spasticity. Short-term, that's where we're usually seeing those. They do have some long-term use too, and I'll talk about those here in a second. Problem with them is most of them are generally pretty anticholinergic and they're generally pretty sedating too. So people don't really tolerate these, like taking them and being at work while they're on them. Cyclobenzaprine or Flexeril is probably the most common one for acute pain. Mechanism, we don't really understand it fully. Again, I kind of talked about some of the stuff these drugs might do, and this one might influence alpha and gamma motor neurons and have some effect on norepinephrine. That's super vague, and again, the mechanism is really vague. No one really knows exactly how these work. Commonly used, generic. You usually don't use this drug for more than a couple weeks. So this is like your person who, I think about, like, you threw out your back, whatever that means, and you're having some lower back spasms, and it's going to get back to normal because it's happened to you before, but you might need a little bit of Flexeril to help you sleep at night. A lot of ED physicians I work with think that this is basically placebo, and I think they're okay with that because they prescribe it in place of an opioid, and they're like, hey, if I can give them Flexeril and they'll take that and I don't have to give them oxycodone, that's a win in my book. So Flexeril is not a controlled substance, by the way. It's not one of them that is. So that's something you could consider as an option for somebody. And I'm approaching this kind of tiptoeing around the issue, but obviously addiction is a big issue, and we don't want to prescribe opioids if we don't have to. So if you can use something else like this, I'm not saying that I agree with them that it's placebo, but that's what a lot of anecdotal providers have told me. I've heard that from a number of people over the years that they don't think it works, but they still prescribe it for those kind of reasons. We'll talk about tricyclic antidepressants during psych, and we'll talk about urine drug screenings during tox. The importance of this is, just very quickly, tricyclics are heavily toxic in overdose. So if you did a drug screen on somebody who overdosed on medications and you're looking to see what they might have overdosed on and it comes up with TCAs, you might get kind of scared. And in that case, cyclobenzaprine can false positive for those. Again, I talked about it being anticholinergic. In large overdoses, it can be a cardiac arrhythmic too, which is nasty. Anything that affects the heart in overdose is something we can't treat very well. So not a good drug to take too much of. There's a bunch of other ones on the market that are kind of the same thing, more or less, and I don't care you know them all for my exam. If you have to know one other one, I'd say know methylcarbamol. Methylcarbamol and cyclobenzaprine are the two most common ones you're going to see. The rest of them get used to varying degrees. Crisoprotol is actually a controlled substance, so we don't see quite as much use in that. But interestingly enough, they all kind of have the same mechanism thing. But ultimately, you can use, we haven't talked about these yet, but benzodiazepines, especially Valium or diazepam, which is used for anxiety and a bunch of other stuff, actually has really good antispastic activity. So a lot of times they'll use that in conjunction with opioids post-spine surgery. It's a really common thing that they do, but we'll talk about that later. So anyway, you can get kind of all over the place from methylcarbamol and cyclobenzaprine, which are controlled, don't really have any abuse potential with them, all the way to like a benzodiazepine, which are pretty highly abused by the general public. So anyway, muscle relaxants are kind of a tricky bag. These two are a little bit different than the other ones. These are more for chronic spasticity. So you have two drugs, tizanidine and baclofen. And if you have somebody who has a chronic spasticity from like a spinal cord injury or a stroke or something like that, they're probably going to be on one of these two drugs. And it probably depends on how they're going to tolerate it. They both have varying degrees of side effects. Baclofen is probably the more common one I see. Tizanidine, I think, is a little more sedating, a little bit more hemodynamically unstable as far as causing hypotension, and it has a bunch of drug interactions. So baclofen's a little bit better of a drug from like a safety profile point of view. They're probably equally as efficacious. If you work in rehab medicine at all, baclofen has a cool intrathecal pump that is actually an implantable pump. This is a kid, which is why it looks really big. It's not that big in real. I mean, if you think about like an adult patient, this is more realistic for the size. But it actually goes into the intrathecal space. It has a baclofen infusion that continuously releases, so it helps with any type of spasticity associated with that. So we see that commonly. We have a big rehab group that practices in our hospital, so we see this quite often. But you won't really see it unless you work with like post-spinal cord injury or post-stroke patients. Okay, let's take a 5-minute break, come back at 4:30, and we'll talk about opioids. There's a lot of slides on opioids. I'll try and clip through them pretty quick here. So opioids are obviously super popular in modern medicine. They're really our best option for relieving acute pain, severe pain. There's not really anything else we have that works for severe pain very well. There's a couple other options maybe that we talked about, but like if you're talking about certain types of pain, opioids are going to be the only thing you can go to. So there's a necessary evil, in my opinion. There's a lot of different dosage forms out there. The side effects are easy to recognize. There's obviously a high potential for abuse, but if you dose them correctly, they're actually generally safe-ish, depending on how you use them or what your definition of that is. They are safe in pregnancy, though, so for pain syndrome and pregnancy, you can use them. This is a poppy plant. If you're wondering how opium used to be harvested, they actually like cut the bulb of the poppy, the opium poppy, and this latexy stuff comes out. They scrape it off, and that's technically what opium is. And then they go on to refine things like heroin from that. So anyway, getting off topic for this lecture, since that's not the purpose of this particular topic. We'll talk about that during the summer. Basic opioid stuff. So analgesia is going to be very minimal. Some opioids are just almost worthless. Other ones are very, very potent. There's no ceiling dose for opioids. It's all about how the patient tolerates it, and as your body gets used to it, you're going to need more to get the same effect. So a chronic cancer patient who's been using opioids for long term might be on fentanyl patch doses that would kill somebody who's opioid naive, and I'm not exaggerating that way. Effective pain relief is limited by toxicity, so you try and give somebody pain relief, but eventually you're going to either sedate them or cause them to stop breathing, and that's your tolerance ceiling, right? So you don't want to kill the person you're trying to manage the pain on, but eventually that's what happened with an opioid. So we have to balance that. We don't want a person to be overly sedated, or you have to use them judiciously. So when can the person take this? That's why, like in the post-operative period, they're nice because the person's in the hospital. It's not like they have to go to work or anything like that. But in the real world, how do you manage somebody who's on opioids chronically? Like, can they drive a car? Can they be at work? Like, what are they responsible for? Those are all real questions you may have to encounter depending on what kind of what kind of patient you work with. Opioids don't do anything to the actual pain, so it's not like NSAIDs where they're actually stopping inflammation. They're just altering your brain's perception to the pain, and I'll talk about what receptors they hit here in a sec. Sedation is minimal to significant depending on the drug you take. Some opioids are just used almost as sedatives by themselves. They work well in combination with other drugs, so NSAIDs, benzodiazepines, and generally speaking, if you combine them with something, you're going to get better control than if you had just one of the options. So there's a lot of good studies out there that'll say that NSAIDs plus opioids or benzodiazepines plus opioids, even though that's a little tricky too, because I don't want to advertise for that too much, because some people say, well, benzos and opioids, they're supposed to take like Xanax with oxycodone. Well, no, not really, but in some situations it makes sense to combine them because you do get a synergistic response. Again, like a post-spine surgery patient where you're having spasticity plus pain, that's a good example of somebody where you might actually combine the two. But yes, it's dangerous to do that. Respiratory depression certainly is an issue. So anyway, not to talk about synergy too much here. Opioid receptors, so you've got a couple different ones. The biggest one we're looking at is the mu1 receptor. So these are receptors that are in your brain, and your natural endorphin system releases and interacts with them. So you're responsible for things like pleasurable feelings, and dopamine's kind of connected into there too, which is why we'll talk about dopamine and drugs of abuse and stuff like that in a little bit. But basically, you've got a receptor that already is designed to work, and somebody made a drug to interact with this receptor, and here you go. Or found out, I shouldn't say made, somebody smoked opium back a long time ago at some point and realized that, hey, it made me feel pretty good. And there we go. Here we are today. So this has been around a while. It's not like this is something new. People have been making opioid and opioid analogs for centuries and trying to figure out how to control pain without causing people to be hopelessly addicted to them. And no one's really conquered that one yet. The problem with these are the mu2 receptors, which are in the lungs and other places. The big one is respiratory depression. Other things don't happen quite as much. A fair number of people will report nausea and vomiting compared to the general population. Kappa receptors are kind of structurally similar, and most standard opioids don't interact with these. If they did, they'd cause the opposite effect of dysphoria. People don't feel very good when they take something that interacts with the kappa receptor. However, kappa receptors can cause analgesic relief on their own. So there might be some pharmaceutical playing around with, they could manipulate that kappa receptor to not cause as much dysphoria, but have analgesic components. You might end up with something that's a real winner as far as a pain management drug, but at this point, we don't have anything like that. And the delta receptor is not something I really understand all that well, so I'm not going to talk about it. Classic opioid adverse effects: sedation, altered consciousness, low respiratory rate. Cardiovascular stuff is rarely seen. Like, I don't think of opioids as going to tank somebody's blood pressure. In fact, if you gave me the choice of sedating somebody and their blood pressure was low, I might choose a high potency opioid like fentanyl, because it's probably not going to drop their blood pressure. You might see a transient drop in heart rate or blood pressure. That could be because they're feeling a little bit relaxed. Constipation is a big one, especially for people who are chronically taking opioids. Anybody who's on opioids should be on a bowel regimen, no exceptions. That's something you should always think of if you're thinking about prescribing opioids. Even if you're giving somebody a PRN, I don't know, like a Norco or a Vicodin or whatever you might want to call it, if you're giving it to them in urgent care or acute care, even if it's like 10 days, just at least tell them to consider getting something for bowel, because these will constipate people on one dose. That's usually going to happen. And that's just part of the way they work. They work in the GI tract. Constipation is a natural side effect with an opioid. In fact, we use that to our advantage in some cases by treating diarrhea with opioids. So that's just going to happen to people. Nausea, vomiting, again, I talked about that a little bit. Difficulty urinating, not as big of a deal as constipation, but still an issue that happens occasionally. Small pupils, pinpoint pupils, is kind of a hallmark of opioid overdose, but again, might interfere with sight a little bit, but probably not. This is an interesting one, is opioids can cause histamine release, and the more natural the opioid, we'll talk about them in progression from natural to synthetic, the more likely it's going to cause a histamine release. So if you want to get rid of that allergic response people get from opioids, it's not that they're having anaphylaxis or any type of type 1 hypersensitivity. It's just the way that the opioids interact with different receptors in the body causes a release of histamine. That's going to make people itch. And so we give Benadryl or we give hydroxyzine or something like that. Usually hydroxyzine is the common one they give post-op if people are getting itching with opioids. So it's a really common side effect. Does not mean they're allergic to the drug. Physical dependence is, of course, one that is all over media and something we'll talk about here too. Okay, opium. Does opium itself have any medical use? Still a little bit. It's basically 12% morphine and then a bunch of other stuff in there that I don't know exactly what it is. But as far as the active ingredient, it's a diluted form of morphine. It's not really used for analgesic purposes anymore. It's too weak to cause much analgesia. Now, if you consumed a ton of it, would you get an effect? Sure. But there's better ways to do that if we're trying to treat pain. Medical applications, tincture of opium comes as like this kind of brown gunky liquid, and that's used for severe chronic diarrhea. So that's really its major role in therapy still. There is also a product called belladonna and opium suppositories. Belladonna is a derivative of the nightshade plant, and so it's like an atropine-like drug. It's anticholinergic, and you actually give these rectally, and they work locally within kind of the lower GU region and cause some relief for people who are having ureteral spasms. And so that's used for that. So you might see that like in urologic surgical procedures, they use those fairly frequently. It's not a super common item, but in some niche areas, they do use it pretty regularly. That's it. 2 applications for opium, rare. Opioid structures. I said I'd never ask you to know a structure, and now I'm going to go back on that. No, I'm just kidding. I don't care. Gotcha. Funny. So opioid structures, the only point in showing this is they all kind of look the same with exception of our friend fentanyl down here. So these are all just molecules that somebody has taken and kind of said, all right, morphine looks like this. I'm going to add some different functional groups onto it, make it slightly different, and come up with oxycodone. At the end of the day, they all kind of look the same. But the more stuff you add or the more you alter that base structure, the more you get a synthetic like opioid. Even hydromorphone, which is kind of a pretty heavy on the synthetic side, is still pretty close to morphine. Once you get to fentanyl, though, and the fentanyl-like products, you end up with a very different looking structure that still interacts with the receptor. In fact, it's much more high affinity to the receptor than these other ones, but it does have a little bit of a different look to it. So just in case you're curious. Morphine is a really old product that's still quite popular. It's often considered kind of the gold standard for opioid pain. It's really cheap. It's mostly effective. It's not the best option, but I'll talk about that here in a second. It's available orally, so you have immediate release tablets, liquid. Sometimes they use this for hospice patients, so people can have It comes in a really concentrated liquid component, and so people who are kind of at end of life might have something called air hunger, where they're like struggling to breathe. It's really rapid, slow breaths. And we think about opioids as respiratory suppression. That's exactly what you're trying to do. You're not trying to stop them from breathing altogether, but what you want to do is try to slow their breathing so their body can actually take deeper, longer breaths. So it actually slows their rate and helps them breathe better. It's kind of a paradoxical thing. So if you ever see that used in end-of-life care, that's what they're doing with that specific product. It comes as immediate release products. Again, you can give it as like a straight tablet, which will have effect pretty quickly. It comes with some extended release products. There's a couple different ones on the market. These are their brand names. I don't care you know the differences of them, other than knowing that morphine exists in an extended release tablet. MS Contin is by far the most common one out there, but the other ones last a little bit longer. And then it's available IV. Morphine has one of the slower onsets of any IV opioid we can give, but that's not necessarily a bad thing. Sometimes that's good. You want maybe a little bit more gradual of an onset. People might not get quite as high of a euphoric response from it. They also might not get quite as sedated if you give them IV morphine versus something else. The problem with morphine, and probably one of its biggest downsides, is it has active metabolites. So your body needs to have good kidney function to be able to clear those metabolites. If you're renally impaired, you're going to accumulate them, and the morphine is going to be a lot more potent than in somebody who has well-functioning kidneys. So that's where morphine kind of has a downside to it compared to something like hydromorphone, which we'll talk about here in a second. Hydrocodone and oxycodone are both oral-only agents, so these don't come as IV forms. They're really similar. Kind of think of them as the same thing. I think most studies have shown that one's not really that much different than the other. Oxycodone, probably, if you could want to argue it, is slightly more potent than hydrocodone. But that just might be how we look at it. For a long time, all the hydrocodone products were class 3 narcotics, and oxycodone products were C2. So I think everyone has this mental association that oxycodone is more addictive than hydrocodone, when in actuality they're both very addictive and equally abused. So hydrocodone is immediate release products associated with acetaminophen is how you're going to see it. It doesn't actually come just hydrocodone as an immediate release product. It's always going to be coupled with acetaminophen. Norco is the current brand name we use. There used to be a bunch of them. People here probably heard of Vicodin before. That was a pretty common street name, even though that was the brand name of it. Vicodin doesn't exist anymore. The reason is because it's the different amounts of acetaminophen in them. So, for example, Vicodin had 5 milligrams of hydrocodone and 500 milligrams of acetaminophen. And Norco has 5 milligrams of hydrocodone and 325 of acetaminophen. So it's a little lower dose of acetaminophen. FDA came out a couple of years ago and said you can't have any more of than 325 milligrams of acetaminophen in a narcotic-containing product due to overdose risk. So they limited that. So Vicodin technically stopped existing at that point, although it had been generic for many years. When I first started in pharmacy, Vicodin was by far the more common one, and now it's, again, that product doesn't exist. You can only get Norco as far as the brand name goes, but people still call it Vicodin. It's fine. It's the same drugs. Hydrocodone comes as an ER tablet called Hysingla. I don't think I've ever seen this used. I don't necessarily recommend prescribing it. All the products that are long-acting usually come with what's called abuse deterrent tablets. Oops, there we go. So I don't know if you can see on here. This is probably an old bottle, but they usually say on the bottle something like, basically it makes it so it's hard to crush it or get it into a solution that you could inject or smoke easily. And whether or not that's effective is debatable. Where there's a will, there's a way, and people will figure out a way to abuse these things, despite the fact that they're harder to crush or whatever. So anyway, what happened with these abuse deterrents is with oxycodone. So oxycodone is probably one everyone in here's heard of. The immediate release product is combined with acetaminophen, kind of like hydrocodone. However, you can actually get oxycodone just by itself. So without the Tylenol component, you can prescribe plain oxycodone. So that's the big difference between the two, which is really nice if you don't want any Tylenol component. Oxycodone comes as the ER component, which is the infamous OxyContin, and that's a 12-hour product, and it now is formulated as abuse deterrent. So Purdue Pharmaceuticals made OxyContin, and people were abusing it left and right, and so the FDA said, you have to change something with this tablet, and sent it back to them. They reformulated it, got a new patent extension on it in the process, so it worked out pretty well for them, and they made a new product that was abuse deterrent at that point. So all these other companies that made generic equivalents had to figure out their way to make an abuse deterrent one after that. So it took a while for OxyContin to fully go brand new. So it's for fully go generic. So it's been generic for a while now, but for a while there it was obviously a big moneymaker. And of course, there's a ton of controversy around Purdue and their marketing tactics and everything like that. But the point is, oxycodone still exists. It's still a medication that does have some functionality. There's a good use for it, which is long-acting opioids are needed for chronic pain patients. There's no doubt about that, and this is an option for them. So certainly don't let that take away from the idea that it's like all the controversy around it take away from the idea that it doesn't have some decent uses, because it does. It's just, did it get overprescribed and everything like that? Yeah, for sure. Hydrocodone and oxycodone are going to have less itching and going to be more potent than morphine. However, they do still cause a bit of itching. They're pretty inexpensive. The ER products tend to be a little bit more expensive. However, again, they're generic now and relatively cheap. Again, careful with the acetaminophen containing products, especially if your patient already has acetaminophen they're taking on a daily basis. And these are, of course, super highly abused, right? Don't have to tell you guys that. Hydromorphone is Dilaudid. And Dilaudid is probably the most popular IV analgesic right now. I said morphine's kind of the gold standard, but Dilaudid's kind of like a more potent morphine that doesn't have any renal issues. It's about 8 times more potent than morphine. It does come IV and PO, so you have multiple ways to give it. There's a long-acting product. Again, I don't see this used very often. Pretty much if somebody's on a long-acting oral opioid, it's going to be long-acting oxycodone or long-acting morphine. It's not going to be these other weird ones. It's much more common inpatient than outpatient. This is like your standard post-op pain relief medication that almost everyone's going to get some Dilaudid after surgery. And PCAs, so patient-controlled analgesic pumps, are usually going to be hydromorphone as well. Okay, so what is a PCA? I've mentioned this a couple times. It's a pump that looks like this. So this is actually locked, so the patient can't just yank this open and steal all the drug and run away from the hospital, which is good because there's a lot of Dilaudid in there. So anyway, it's a pump like that. It comes in a big syringe, and it slowly infuses into the patient's IV, and the patient can give themselves bumps off this. And you can control all the parameters, so you can control a continuous infusion. So you can say, I want my PCA to go in at this rate, and I want the patient to be able to bump themselves this many times an hour at this dose, and it locks them out after this many minutes and after this many doses. So you can control all that stuff and restrict it. And if that sounds really complicated, the nice thing is that most electronic medical records will tell you all those parameters, and they have kind of default settings. You don't really have to change anything yourself. So that's nice for me, and it's nice for you. But the point is, these are really nice. They're actually pretty well proven that it helps patients stay on top of their pain a lot more. It's really impossible for the patient to overdose themselves on it unless the settings are way out of whack. So it's a relatively safe way to give pain. It doesn't require your nurse to constantly have to go into the patient's room and try and assess pain and stay on top of it that way. The patient kind of can do that themselves. So PCAs are super popular, especially in certain post-op patients. But overall, it's a good option for people to try for those reasons, and especially you can control the amount so easily. Okay, fentanyl. Oh, this is my favorite picture. Somebody did some good Photoshop on this one. So fentanyl actually does come in like a lollipop form like that, so it's not totally a joke, but I'm sure that kid wasn't actually holding it, right? That'd be kind of weird. All right, so fentanyl's a pure synthetic opioid. It's super potent. There's no metabolites or renal elimination. So fentanyl's a nice drug from a number of standpoints that there's not really much to worry about with side effects other than the fact that it's a super potent opioid, right? So that's what you have to be concerned about. Dosage forms, there's no FDA-approved oral form, and you might be saying, didn't Prince overdose on fentanyl? Yeah, he did. Apparently he got fentanyl tablets somehow, and I didn't know that it was a thing, but apparently if you do ingest fentanyl orally, its bioavailability is like 20%, so you will absorb some. And if you absorb even a little fentanyl, that can be enough to cause some significant issues. So anyway, tangent. But there's no FDA-approved fentanyl tablets. It comes as an IV product, which is really popular for procedural sedation, procedural pain, and honestly, it's a really nice choice to give somebody in small doses for just acute pain. I see a lot of my ED providers use it over Dilaudid just because it seems to be a little bit shorter acting. If you give it in, again, really small doses, you get a nice effect. You can give it intranasally too, which is kind of cool. But it's got a really fast offset, so you can treat pain quickly and assess it that way and see how it's going to respond. It comes as this thing called a lollipop, which is not really what it's called. It's called Actique, which is like a transdermal lozenge on a stick. It looks like a sucker, right? You wouldn't want to suck this like an actual sucker. But basically what you're supposed to do is cheek it for a certain amount of time, and it gives you a dose that way. It's for chronic pain use only. It's kind of like an adjunct to some sort of long-acting option. So really just for like cancer patients, but it's an option. And actually that was invented at the University of Minnesota, which is, I guess we invent fentanyl-containing lollipops, which is kind of funny. No itching, super sedating. And while the IV product in little doses could be used for a naive patient, you do not want to use a transdermal product. I had a provider a while ago ask me if they could send somebody home on a low-dose fentanyl patch who had never had opioids before, and that's a huge no-no. That's way too much opioid for a naive person to get. That's a big, there's very strict parameters on what you have to try before you try a fentanyl patch on somebody. Fentanyl patches are nice for chronic pain if you want to avoid giving somebody a lot of pills and give them something continuous, but not in a naive patient. And then drug of abuse. Wow, fentanyl has kind of become the drug of abuse. Everyone's heard of fentanyl being a drug of abuse, right? This wasn't the case like 5 years ago. No one really knew what fentanyl was unless you were in medicine. I shouldn't say no one, but very few people did. I think it's more of an act of that for some reason cartels are getting a hold of precursors. They can synthesize fentanyl at a lot cheaper of a rate than they can manufacture heroin in a field, and they can do it in a lab versus growing opium poppies, and it's super potent and it's way cheaper to make, and now you're seeing it getting cut into stuff and marketed as heroin when in fact it's much more potent. So anyway, that's my side note about fentanyl and abuse, but it's kind of a scary thing because this is way more potent than your standard run-of-the-mill street opioid. Fentanyl patches, in case you're wondering how they work, they have a reservoir system in them, just like most patches. You apply them transdermally in these spots. You can wear multiple different fentanyl patches at a time. So like, let's say you wanted your dose to be, I don't know, 175 micrograms per hour, which is a ton, but sometimes it happens. You could apply 100 and a 75 at the same time. So you can wear them. Just make sure your patients are taking them off. There have been cases where people have left them on, and they do have some residual activity even after the 72-hour window. You apply them once every 3 days for most people. And if you accidentally forget about them, they're clear when they get placed on, so you could easily not see it potentially, especially if you put it on your back. You could end up with a lot of fentanyl kind of leaching into your system over time. Disposal, even after being used, these are super dangerous. If a pet gets a hold of them and chews on them, or a kid does, not that I don't think a kid would really chew on a fentanyl patch, but you never know. That can absorb buccally, and they could overdose really quickly on that. So that stuff there's a lot of fentanyl in a patch. If you work out 75 micrograms per hour, and how many hours? 72 hours. That's quite a bit of fentanyl that somebody could possibly ingest. So anyway, be careful with your disposal on those, or your patient's disposal, I should say. Other fentanyls I don't want to spend a ton of time on. They aren't really as relevant in this lecture. They're more procedural related. You'll see different surgeries use these for different levels of sedation. The most common one we see besides regular fentanyl is remifentanil. And why they're all spelled with an I and regular fentanyl is with a Y, I have no idea, but that is actually correct. Remifentanil is what they use that for is they call it like for a deeper level of sedation. So patients where they do neuromonitoring cases where they want to see like the brain activity during a case, for some reason, again, this is beyond my pay grade, get into neurosurgery realms, but they use Remi. So I don't know why, but it has a similar potency to fentanyl, but it's got a super fast onset. So I think it just produces sedation much more quickly, and you get a deeper level because you don't have to worry about that onset and the metabolism happening kind of at the same time. So anyway, I'm not going to test you on other fentanyls, so don't worry about them. Just regular fentanyl with a Y. Okay. This is a nice chart just to compare onset. So again, Remi and L-fentanyl have like almost instantaneous onset, whereas everything else is going to take a little bit more time to fully realize it. I mean, if you gave somebody an injection of fentanyl, they're going to feel it pretty quick, and most of these things are going to feel some, but this is sort of your peak onset period here. And you can see the different lasting, like hydromorphone, morphine, going to last, this is minutes, so they're going to last several hours, whereas fentanyl is going to start to leave the system pretty quickly. So if you want to sustain fentanyl, you usually need to either give another dose or give it in a continuous drip of some kind. Meperidine is Demerol. It doesn't have any role in pain management. I only mention it because it was a historical pain management medication, and it's toxic, so we don't use it. We use it in really low doses for people with rigors. So if they have shivering, like post-op, that happens sometimes, where it's common where they might be kind of shivering and shaking a little bit. They'll give a little bit of meperidine, and it works really well for that. That's it. That's all I want you to know about it. Methadone is the longest half-life for a non-extended release opioid. It's got 24 hours. However, it's got kind of interesting kinetics where it doesn't really have a long duration at first. You have to repeat your dose. It's also somewhat useful in acute pain management. It has somewhat of a fast onset, so it can be used then. I just don't see methadone used all that much. I think people are hesitant to use it because it's associated with opioid dependency. And there's a lot of prescribing restrictions around it for opioid dependency. For pain management, there's actually no prescribing restrictions. So if you want to prescribe methadone for pain, you don't have to have a special DEA number or anything like that. For treating opioid dependence, you do have to have one. So I think people are just like, I'm not going to deal with methadone. That's not necessarily a bad idea, but it is kind of an interesting drug. It is a mu agonist, just like all of our opioids are, but it has NMDA antagonistic properties. NMDA receptors cause like a dissociative-like experience. I think about NMDA receptors as a communication between the brain and the rest of the body. So if you're kind of like blocking those, you're resetting the way the body might process pain through those pathways. So a little bit different of a mechanism. Also, serotonin and norepinephrine reuptake inhibition is a common antidepressant strategy and also useful in neuropathic pain. So methadone has some really interesting properties that go beyond an opioid, which make it possibly useful for other conditions. Yeah?
So why do they use this for people who drug addicts kind of like wean them off?
Great question. So it's got a really slow onset and it doesn't really cause a lot of euphoria, yet it hits all the opioid receptors. So the idea is you're giving somebody something that's going to prevent them from going into withdrawal, but also prevent them from getting high. And they might get a little bit of a high off methadone, but at the doses we use it at, it's really not. So that's the big reason why they use it. And actually, there's a drug that's probably a little more effective than that. We'll talk about here in a second. But methadone's given orally for that reason. So you never give that IV for withdrawal. So you always give it orally. So it's got some ingestion time associated with it as well. Usually people have to go to methadone clinics to get methadone, which is a big problem in my opinion. It puts a big stigma on it. Oh, I got to go to a methadone clinic. You have to go during the clinic hours. Sometimes you have to go every day. Like they don't always give take-home doses to people. So it can be really challenging for the average patient to get in to methadone clinic. There is another option, fortunately, which we'll talk about here in a second. But that's kind of the major mu opioids. So I am going to have you guys do some opioid calculations for the next exam. This makes people nervous. But I'm going to give you some practice problems that basically tell you what to do. So if you do well on the practice problems, you'll do well on the exam questions. They're very, very similar. And it requires doing some math. So what I'll give you on the exam is a very specific conversion. So I'll give you a question of a patient going from one opioid to another. And this happens really commonly. You might have somebody who is inpatient who is using quite a bit of hydromorphone post-surgery, and you want to convert them to an oxycodone regimen, and that's oral, and taper them off slowly. You need to know how to convert opioids. So I think this is relative to a lot of different practices out there. Maybe not your ideal practice in the future, but certainly enough people will encounter this where I think it's important. So I'll give you a question that talks about somebody using a certain amount of opioid. You'll have to add up their total daily dose. I'll give you a very specific conversion in the question saying 1 milligram of hydromorphone is equal to, I don't know, what's the better one? 10 milligrams of morphine is equal to 1.5 milligrams of hydromorphone or something like that. And you'll have to do the math there. And again, I'll give you some very specific questions that'll tell you how to do it. It's basically like really simple fractions is how you do the math. So I'm confident in all of our abilities to do this, but I think it's important just to know how to do it. In case you're wondering how to use fentanyl patches, you convert everything to oral morphine equivalents, and then you figure out what fentanyl patch you need to do. So if you're wondering, like, how do they make it, how do the transdermal work with that? That's how they do it. So I don't know. That's how they've done it forever. Tapentadol is Nucynta. It's an immediate and extended release tablet. A mu agonist and an inhibition of norepinephrine reuptake. So it kind of has some of those similar effects that we're seeing in antidepressants and neuropathic pain agents. It's marketed as a more tolerable option with less GI-related side effects. I don't see tapentadol used a lot. Every once in a while, it's quite rare. I don't want you to know it for the exam, just FYI. Sorry for putting a whole slide on it. Doesn't deserve it. Buprenorphine is one that's kind of important. So it's a mu partial agonist. You can use it for pain management. It's kind of like, think of it like a half opioid. It's not going to work quite as well as like oxycodone, but probably better than some other options we might discuss here in a second. So like codeine and tramadol, I think those are like the really weak opioids, which we'll talk about here in a second. But buprenorphine, kind of in the middle ground here. While it could be used for pain, where it's actually useful is an alternative to methadone. So again, it kind of has the same effect of methadone, where it gives you the it's got really high affinity for mu receptors, so it'll bind over like a heroin or a fentanyl even. If you have if you're on buprenorphine and you inject yourself with some sort of street drug, it's going to be really hard for that street drug to take over the receptors from the buprenorphine. And buprenorphine itself doesn't cause a substantial high effect, maybe a little bit of euphoria when taken in excess, but when used at controlled doses, it kind of just produces sort of like, it hits your receptors, gives you some pain control, it might give you a little mild euphoria, but that's about it. Where it's used as a opioid-dependent drug is combined with naloxone, which we'll talk about here in a second, is a drug called Suboxone. Suboxone has a lot of advantages over methadone because you can get it at a regular pharmacy, it doesn't require weird prescribing restrictions, and so there's a lot of other nice advantages to Suboxone. Just the stigma alone is greatly reduced. There's actually some really good studies that show that especially younger patients, like patients in their teens or early 20s who are diagnosed with opioid dependence and are prescribed Suboxone or methadone, do much better on Suboxone than they do methadone. So I wonder if we're going to see the younger generations of opioid-dependent people, whatever that noise was, be more on Suboxone. I think I already have seen that in the hospital. Methadone patients usually are older. Suboxone patients tend to be younger. So. Oh, and in case you're wondering why it's combined with naloxone, naloxone is an opioid antagonist, which we'll talk about in a second. And the idea is so that you don't give somebody who might be at risk of IV drug use something that they could grind up and inject themselves with. If they decided to like dissolve that film or the tablet and shoot it up, they would end up shooting themselves also with naloxone, which would reverse any effects that the opioid would have at the same time. So that's why that's in there. The naloxone itself orally does nothing. All right, cough suppressants / really poor opioids. Codeine. Codeine is metabolized into morphine at like a 1-to-10 ratio. So technically it is a real opioid. It's not just a cough suppressant, but clinically it's most often used probably as a cough suppressant, as various different forms of cough syrup. Does it work? Probably not. It's also combined as Tylenol 3, or T3 is a common abbreviation for that, and that's 30 milligrams of codeine and 300 milligrams of acetaminophen. Weak analgesia. What people use this for is when they don't want to prescribe like a full oxycodone or hydrocodone. They want to give some oral opioid that's not an NSAID or something in the middle. Remember that middle ladder of our WHO ladder? That's where codeine fits in right there. My boss, side note, my boss's neighbor is like a DEA agent or something, and he said that codeine is like the most popular abuse drug right now. That's one of the biggest trafficked drugs, which is really strange because I don't know why you would abuse codeine if you had your choice. Maybe because it is lighter and you can take more without dying, but apparently they're saying that that's a popular drug of abuse right now. So interesting. Dextromethorphan is not really an opioid, but the structure was designed after opioids because we know opioids suppress the cough reflex to a certain degree. And so they said, well, let's make a drug that doesn't cause opioid effects and suppresses cough. And there you got dextromethorphan. Dextromethorphan doesn't really work based on any statistical studies you read, but people will take it. I mean, how many people here have taken Robitussin at some point in their life? Probably more relief from actually taking the syrup than anything else. But anyway, it's out there. It's worth a shot. It's very harmless at low doses. People take, sometimes, I shouldn't say this all the time because I have no idea, to be honest, but apparently people take lots of this and they call it robo-tripping, which I think is a funny name, hence my robot here. And it does actually cause pretty significant hallucinogenic like effects when you drink a ton of it. So especially if you take Delsym, which is a controlled release version, that one will catch up with you in a bad way, apparently. And I'll talk more about that in drugs of abuse. We'll talk about those, where I learned my weird factoids like that. Not from personal experience, I promise. Okay, antidiarrheal. So we talked about as far as opium, that you can use that for people who have chronic diarrhea. But what about the other way around? Like if you want to, as an same thing, right? Okay, so Lomotil is diphenoxylate and atropine. It's kind of an odd drug, and the reason why atropine's in there, it's an anticholinergic medication. Yes, it might slow down the GI tract. However, it's just in there so you don't grind up the diphenoxylate and try and inject it. Now, why atropine? Who thought of this? I don't know. It's really bizarre. But anyway, there it is. It's a deterrent agent. It's a controlled substance weekly, though. It's a C5, which is the lowest control status you can get. I have no idea why somebody would try and abuse this, but apparently they might. Basically, you take it. If there's no response after 48 hours, it's likely not effective. You can take it up to 4 times a day. Loperamide is over-the-counter, Imodium. That's also an opioid-type analog that's designed as an antidiarrheal agent, not absorbed systemically, dosed 4 milligrams one time. I'll talk about these again when we come back to GI, so don't worry about this for this exam, just as a reference here, since we're on the topic. Opioid-induced hyperalgesia is increased in pain sensitivity following exposure to opioids. Kind of an interesting phenomenon. People who are really on massive doses, maybe they're chronic cancer patients, they'll hit kind of a wall where all of a sudden they get this really intense pain response. And it's well documented in animals. Humans, it's kind of rare, but seen. Ketamine, we were talking about this at the break briefly. I haven't really talked about ketamine yet. I'll talk about it more in detail, but it's an NMDA receptor antagonist. So again, it kind of blocks that transmission from brain to body at those particular receptors. Is also used to do this. So that's kind of the drug you give if opioids aren't working. I've had people in our ER where we're slamming them with more fentanyl than I thought was humanly possible. Nothing's touching them. You give them ketamine and they actually respond really well. That's kind of the next step. And actually there's probably a lot more research going on with ketamine right now, and we'll see more use of it in the next few years in pain, in mental health, and other things like that, depending on it. It's not a perfect drug, but again, I'll talk about it a little bit more when we talk about mental health and some other areas. Okay, that's all I want to talk about with that. All right, how do you reverse opioids? Naloxone, everyone here has heard of Narcan. It's a pure opioid antagonist, competes with and replaces opioids at site of action. You can give it IM, IV, sub-Q, neb, nasal, however you want to give it except oral. Everything else works. And you wouldn't really want to give this oral anyway because it's an emergency drug in the most case, so that defeats the purpose. Onset's in minutes. It lasts about 30 to 120 minutes. This is important because most of our opioids last longer than that. So if somebody ODs on heroin, you're going to have to redose them or start them on a Narcan drip, or they're going to go back into the opioid respiratory depression cycle. Be careful. You can kill somebody's high and they can get really mad at you and very agitated. I've seen it before. It's not pleasant when a nurse gets like a fist swung at her because she gave, well, it's not her fault. It's the doctor who ordered the wrong dose, probably. So be careful. You know, obviously, if somebody's dying, that's different. Slam them with Narcan. Don't worry about overdosing them. You know, an agitated patient is better than a dead one. But if somebody's kind of like on the borderline, you're like, this person's really sleepy. They aren't breathing very well. We might have to intubate them. Let's give them a little Narcan. Start low. Remember, it works in minutes. We can kind of work our way up to there. Post-operatively and procedurally, a lot of times they'll give a little bit of Narcan if the opioids aren't wearing off fast enough post-procedurally. Healthy patients, probably not a big deal. Older patients is where you might see that more, where you might just have to give them some baby doses to kind of perk them up a little bit at the end of the procedure while that fentanyl is wearing off. Again, everyone's probably heard of this. It's been big public campaign about Narcan. People can get Narcan over the counter. Well, kind of. Pharmacists can dispense Narcan now. It's sort of like a collaborative practice thing. It's basically over the counter. You don't need a prescription for it. Anyway, so this gets handed out in our emergency department. If you have an addict in your family or a friend who's an addict or anybody, it's a good option for people to have in place just in case something happens, especially if your patients have like a loved one who uses IV drugs or something like that. It is shown to save lives in the community, and it's really essentially a completely benign medication to somebody who doesn't have opioids on board. So even if somebody like passed out and you're like, hey, maybe they have opioids, and you're like the first responder there and you give them some Narcan, if it doesn't do anything, you didn't do anything to the patient. It literally does nothing to somebody who doesn't have opioids on board. And again, I said you can give it as a continuous infusion. Kids talked about. Anyway, Narcan's kind of a big deal right now, so there's that. Naltrexone is a long-acting antagonist that's usually used a couple different ways. One is PO. It has an up to 72-hour duration, and it's mostly used for people who have opioid-induced constipation from that perspective. and a couple other things, but that's pretty much it. Where we see it more so is like the IM component is called Vivitrol, which is an every 4-week injection, and that's for opioid dependence. So that's where it's used for that. It's actually used for alcohol dependence as well. So that's the more common product. PO I don't see used a whole lot. Technically, you could use the PO for opioid dependence, but it doesn't absorb all that well from the GI tract, and then you're relying on somebody to actually take the medication. So the IM product is infinitely better in that situation. Again, it's pretty benign if you're opioid naive. Major danger is precipitating withdrawal in an opioid dependent patient. Why it works in alcohol dependency is a big question. It doesn't really make any sense. The thought is that somehow abusing alcohol triggers in a roundabout way the mu receptors somehow get stimulated through a pleasurable reward response that your brain's undergoing, and it stops that cycle. So it works for some people, not for others. It's not a great option, but it is one that if you take it and you inject something, you're not going to get a whole lot of effect because that drug's circulating in your body. All right, antagonists for specific symptoms. Nalbuphine is a partial agonist. It's really just used for opioid-induced itching. The only place I ever see this used is in OB patients post-epidural. Why it doesn't get used elsewhere, I don't know. It's really rare to see it, but that's where they use it a lot. So that's all I'll say about that. Methylnaltrexone is a peripherally acting mu antagonist. It doesn't cross the blood-brain barrier. So this is actually a really great drug for treating opioid-induced constipation for chronic opioid people like cancer patients I think of would benefit from this the most. If they don't get a bowel movement from a standard bowel regimen, you can use this drug and it should produce a bowel movement within an hour. It actually is relatively inexpensive, I think, for how infrequently and how nice it can be for those patients struggling with that. So that's just, again, a side note. I'm not going to test you on either one of those two drugs because they're very niche. Chronic pain strategy. Okay, let's talk about this very briefly. How do you treat chronic pain? Basically, you want to assess daily pain medication use. Start with, if they're using a lot of short-acting medications, consider starting a long-acting agent, and then convert their total daily dose to morphine equivalents. Look at selecting a long-acting agent and starting patient on this. So you really want to assess your patient and see what are they using. How much of what you're prescribing are they using? So let's say you start them on a low-dose long-acting agent and some PRN meds, and they're maxing out all their PRNs. Well, that means you probably should go up on the long-acting agent a little bit, assuming, of course, it's therapeutically responsible to do that. Long-acting agent options are fentanyl, morphine, oxycodone. I mentioned a couple others, but those are really the big three. And patients should always have something for breakthrough pain. So the point is not to give somebody just long-acting opioids. They should have long-acting and some short-acting thing available for as-needed use. Cross-tolerance is common, so that means that if somebody switches from one opioid to another, you can actually decrease your total dose because they're going to get more response because it's a different chemical. So if you started somebody on hydromorphone and then you're switching them to fentanyl, that fentanyl equivalent dose is actually going to be lower than their total Dilaudid dose that they were on because of that cross-tolerance phenomenon that happens, usually by 25 to 50%. Where did my side go? Withdrawal. Withdrawal occurs, and I'm going to go through a case on this during the next lecture, so we'll talk about that again. And I'll post the problems, so if you guys want to get ahead, you can look at them and how they're laid out. Withdrawal usually occurs after 3 weeks of daily use. Severity depends on drug, dose, and length of use. Usual symptoms are 3 to 4 hours, craving, anxiety, fear, 8 to 14 hours, restlessness, insomnia, yawning. You start to get the GI-related symptoms as well. 1 to 3 days, tremor, muscle spasms, vomiting, diarrhea. And if you get through that, that's about it. It's very rare to have fatalities due to opioid withdrawal. Basically, the only way that would be possible is if you were really kind of a fragile person to begin with, like if you're really malnourished or had some other underlying health conditions going on, and that kind of put you over the edge. Somebody who is relatively healthy other than maybe being on a lot of narcotics shouldn't have any type of fatal consequence from this. They're going to feel super uncomfortable and miserable, yes, but any opioid could be used for treatment. Again, the best way to do this would be to start them on some sort of drug you'd already used for treatment as opposed to giving them a different opioid. So give them methadone or buprenorphine to help combat those withdrawal symptoms but not cause some sort of a euphoric experience. Antagonists can be used like naltrexone, clonidine, can help with some of the somatic-related side effects. They use that. It's kind of effective, not super effective. Benzodiazepines can help with anxiety, but that's just giving somebody who's already been addicted to a substance another addicting substance, which is generally not something we do. Antiemetics, of course, could be used to manage the symptoms as well. So those are kind of going to be your drugs of choice there. Itching, antihistamines. Hydroxyzine is usually the one we prefer because it is less sedating than diphenhydramine, but either one would work. Talked about nalbuphine already. Constipation, we'll talk about bowel stuff when we talk about GI, but that's kind of the general thing. Again, the moral of the story is to have a bowel regimen on board for a opioid patient. Just to talk about addiction very quickly, even though it's a big topic, we'll kind of come back to drugs of abuse a little bit during the summer and revisit this. But risk is about 3 to 5% of patients who take an opioid possibly could develop some sort of an addictive tendency to it. And I went to a talk from an addiction medicine physician from Hennepin once, and he said something that kind of resonated with me, that basically, like, if somebody was going to take an anticoagulant, the risk of bleeding, a severe bleed, is like 3 to 5%. So you would educate them on that, right? So this is the same thing. If you give somebody an opioid, you should educate them on the risks of addiction. And talk to them about their family history of addiction or their personal history of addiction, because last thing you want to do is prescribe it to somebody who you don't know is maybe an alcoholic, and you didn't know that at the time of the visit. Many challenges with prescribing and dispensing. There's obvious street value with these things. There's doctor shopping. These things happen, unfortunately. The best deterrent is not only your own intuition, which listen to, but also there's tools we have at our disposal. So not only do you have an electronic medical record in most situations to look into the history, but the Minnesota Prescription Monitoring Program, in fact, a lot of states have these. I think almost all of them do now. But you can register with us once you have a DEA number. And actually, you don't even need that, I don't think. Maybe you do as a provider. Anyway, you can register at this. It's really simple to do that. And then you can look people up. It's basically a name and date of birth search. And then you can see what pharmacies they filled the medication at and who's prescribed it. So it's really easy if you go into the PMP to see, oh, this person fills oxycodone 60 milligrams and oxycodone 5 milligrams every month, same doctor, same pharmacy. Pretty straightforward pattern. Or you see somebody who's got like 5 pharmacies and 6 different providers on there in multiple frequencies and they're paying cash. That's, of course, a red flag. So it sounds kind of silly, but you never know what you're going to find. And if you ever have any inclination to thinking somebody might be trying to scam you, don't worry. Don't feel bad about looking them up. You don't have to tell them you looked them up. I'm going to go check this monitoring program because I think you're trying to dupe me here. You don't have to. You don't have to get their consent to do this, which is nice during the prescribing process. And pharmacists don't have to do that either when they're dispensing. So if I'm a pharmacist at Target or whatever, dispensing a narcotic that you prescribed, I can be like, this person's kind of acting shifty. I'm going to look them up. They don't have to get the consent either. So that's a nice way you can kind of secretively do this without offending somebody, right? And don't be afraid to do this. Please use it. That's what it's there for. Abuse of oral products that we prescribe for legitimate medical reasons is very strongly linked to IV drug use. There's no question about that. The people who abuse oxycodone might eventually go to an IV product because they're easier to get and they're cheaper, and they produce a better high. So eventually that's the way some people end up going. Okay, a couple more slides, guys. Bear with me. Ultram, tramadol. Tramadol is kind of an opioid. It has some weak mu activity, but it's more associated with reuptake of serotonin and norepinephrine, kind of like our antidepressant classes. It's oral, it's regular and extended release product, but I don't really see the ER, mostly the regular. It's usually used as needed, and I rarely see this used scheduled. So it's kind of like, again, that middle ladder of the WHO algorithm. You don't want to prescribe a full opioid. Your NSAIDs aren't cutting it. Tramadol is where a lot of people fall. Creatinine clearance is limited in patients with severe renal dysfunction, and often used in conjunction with NSAIDs to avoid starting your actual opioid. Lidocaine patches. I talked about cane-type drugs at the beginning of this, so all cane-type drugs basically do the same thing. They block neuromuscular impulses, and so they cause a kind of numbing effect, basically. So lidocaine's used all over the place. Topically, pre-incision site. You could use it before you start an IV in a patient. But somebody made up these patches, and usually they're used for post-herpetic neuralgia, but they could be used for a number of different conditions. It's another topical option you might have for a patient when other options aren't working for them. Yes?
How long do these take to set in?
Usually a transdermal product takes a couple hours to start, but once you get a depot effect and you replace it, you usually get, this is a little different because you're supposed to leave it off, but usually when you replace the patch, you retain the depot effect unless you're rotating sites, which you might do if there's irritation, and that can help keep kind of a continuous response there. This is different. Lidocaine's cardiotoxic if you overdose on it, and so to prevent that from happening and absorbing too much systemically, it's something that they recommend taking off for 12 hours at a time and then putting back on. These patches are really big. That's the full size, and you can put up to 3 of them on at a time. You can also cut them and put them wherever you want. So it's really convenient for people to do in multiple different ways if they have odd places to put the patches. And neuropathic pain. So neuropathic pain, even though it's a huge topic, I'm just going to touch on it a little bit. Multiple sources of neuropathic pain, the most common ones listed there. And other types of pain, as with everything, we want to avoid using opioids. But in as far as neuropathic pain, you just have no real reason to give an opioid. They might work synergistically, but that's not what you should generally be using. So somebody on opioids for neuropathic pain would be a kind of an odd thing to see. So usually you aren't going to see that. Anyway, pins and needles, burning, tingling sensation. We haven't really talked about the drugs, so that's why I'm going to skip over them quickly. We'll come back to them, so if you want to use this for reference later after we talk about these drugs. A couple different classes, 2 different ones that are used mostly. Anti-epileptic drugs, gabapentin, pregabalin, and carbamazepine are the most common ones there. And then antidepressants are tricyclics, which are older and kind of sedating, or serotonin norepinephrine inhibitors, which are drugs like Cymbalta. I'll mention Cymbalta next week a little bit because it's gotten some ground in actually treating osteoarthritis now, but it was originally designed as an antidepressant. So those are the drugs. Again, we'll talk about these drugs in much more detail during those specific lectures, so we'll come back to them.